session is about history taking in gynecology and obstetrics. History taking is a very useful tool in making a diagnosis in all aspects of medicine. And it's very important that one learns how to take this history. Our learning outcome at the end of this session, you should be able to take gynecological and obstetric history in a systematic manner. 2, you should be able to take the history of the presenting complaints. And 3, you need to know what constitutes gynecology history, obstetric history, family and social history, and perhaps systemic history. For a good and relevant and informative history, one needs to establish a rapport with the patient. The patient's information must be kept secret. And again, the clinician must radiate confidence as for the patient to be able to establish trust in him or her. Usually, history is obtained in a particular order, but this is the order that I prefer. You start by asking for the name of the patient, then the place of residence, so that we can determine the cultural, the background of the patients. We need to have an idea of the age, so one needs to ask for the age of the patients, because there are age-specific diseases, and there are variations from puberty to adolescent to young age to childbearing years, premenopausal and menopausal years. After getting the age, one needs to ask for the educational status, the level of education attained by these patients, that primary level of education, secondary level, or tertiary level of education. Again, prognosis of most diseases are worse in women that are poorly educated compared to when they are highly educated. In our clients, we need to ask about the tribe. See it, whether a white, black, or whether it's Igbo, Yoruba, or Hausa Fulani. This is very important. The religious beliefs are also important. You need to ask, is he a Muslim, a Christian, or a non-believer? Because again, our approach to health-seeking behavior depends on our religious beliefs. Like we know that some religions are very critical. Some do not take blood transfusion like we have in Jehovah's Witness, and some do not go to the hospitals at all because they do not take drugs, just like people in the Christ Apostolic Church, or they just take holy water. Again, it's important to ask for the marital status of your patient, whether the woman is single or is married. I always like to take obstetric history first, and in this particular history, it's important to ask for the number of children the patient has had, the ages of these children, and then the birth weights, and the outcome of the deliveries, whether the babies are alive or dead. It's very important to know these facts. The number, the ages of these children, their birth weights, if the woman or the patient can remember, and then the outcome at birth, whether alive or baby. It's also important in this segment to know the type of abnormalities of pregnancy that occur when in those pregnancies, like premature delivery or preterm rupture of membranes, or even simple anemia in pregnancy. You need to know all these things. Or there are bleeding. The same thing happens, the abnormalities of labor. Whether the labor was prolonged, it was obstructed, or it was accompanied by surgery or assisted vaginal operations. And also, in the immediate period following childbirth that we call puerperium, we need to know what obtained at that level. It's also important that we know the number of miscarriages when we are taking obstetric history, and the stages at which these miscarriages occur, very important, or any other complications that may arise. And if there is any termination of pregnancy, like spontaneous abortion, inevitable abortion, we need to know the particular gestational age at which they occur. And at the end of this history, that's the way we describe the obstetric history as gravida X para Y 000. That is, the first G is number of pregnancies. The number of pregnancies may be more than the number or than the parity. The parity is the baby that is delivered per vagina, while the gravida is the number of pregnancies. The 0 that follows the P is whether there's any abortion or termination of pregnancy. And the next 0 is what called how many of these that were delivered before 37 weeks are called prematurity. And the next A is the number of babies that are alive. That's the way we record it. We record it. If the woman is not pregnant, we do not talk about gravidity, but we talk of parity. We talk of parity as para 0 or A. But in case the woman too is a teenager, we just say it's a nulliparous that has not given back or gotten pregnant at all. After this obstetric history, we go to the gynecological history. And in this, what constitutes gynecological history essentially as a menstrual cycle. We want to know the age of menarche, when the first age at which the woman starts to menstruate. That's the age of menarche. And we want to find out about the regularity of the menstrual cycle. In this regularity, you want to know the duration of the menstrual cycle, at least when from the first day of the last menstrual period to the first day of the next period. That's the duration of that cycle. That's the length of that cycle. And then you find out how many days does she normally bleed in that cycle. Usually, the normal days of bleeding is between 2 to 6 days. 2 to 6 days. Some cases may be 2 to 8 days with an average of 6 days. In our environment, we use 2 to 6 days. 2 to 6 days with an average of 4 days. Yes? So, and the age, the way we summarize this in our writing, we talk of M, menstrual history, 12/4/28. That means she attained menarche or she starts to bleed at 12 years. The duration of the cycle is 28 days and duration of bleeding is 4 days. And then we want to find out at this sexual history, want to see whether there is any concomitant pain, what we refer to as dysmenorrhea. And then you need to distinguish between a primary dysmenorrhea or a secondary dysmenorrhea. A primary dysmenorrhea is a painful menses that starts from menarche. And a secondary dysmenorrhea is one that starts several years after she has attained menarche. The difference is that the secondary dysmenorrhea results from a pathology in the genital tract, like infection or a growth in the genital tract, either on the cervix or on the uterus. So we need to distinguish between a primary dysmenorrhea and a secondary dysmenorrhea. At the same time, when we are asking for dysmenorrhea, we want to ask if the woman has painful intercourse. Painful intercourse is what we call dyspareunia. So you need to know it. So if there is a painful dysmenorrhea and a painful intercourse, that suggests there is a problem in the genital tract, in the reproductive tract. And that idea will be pointing in the direction of endometriosis or pelvic inflammatory disease. Again, we need to know the regularity, the frequency of intercourse. Most women, particularly those women that are infertile, many of them will want to get pregnant without having intercourse. So it's very important to establish the frequency of the intercourse. Is it once a week? Is it twice or thrice a week? Again, as part of the gynecological history, we need to have a knowledge of contraception. Is this woman on any form of contraception, either oral contraceptives, injectable contraceptives, or a mechanical form of contraceptives? Because the knowledge of contraception will help you, will help the patient, will help the clinician and the patient to be able to look at the problems in view. Yes, after you have taken this obstetrics and gynecological history, then you now go down on the presenting symptom of the patient. Why has the patient come to you? So in this particular presenting symptom, it's very important that you allow this woman to tell her story without any interruption at any stage, except you want to get some clarity in what the woman is talking to you about. So in getting these presenting symptoms, you need to obtain a brief statement of what is happening, the nature, and then the duration. And at this point, one needs to know that women may come with a variety of symptoms. Some of them will come with back pain, some things going around my body, my backache, and what the rest. But what you need to do, you must establish what you call the chief complaint. This chief complaint may be abnormal menstrual loss, it may be a pelvic pain, it may be an increasing abdominal gut, or absence of a menstrual cycle since birth, or absence of a menstrual cycle after a pregnancy loss. It may be a difficulty in getting pregnant. It may also be protrusion from the vaginal wall, or it may be a vaginal discharge. So any of these could be the chief complaints. You may help the woman to identify the chief complaint. Once the chief complaint is identified, it's also important to look for how long has this chief complaint started. How long? Yes, and what preceded these complaints? What started it? How did it start? For how long has it started? What makes it better? Or what makes it worse? If it's a pain, for instance, what aggravates the pain? Or if you sleep on your left or right, does this pain disappear? So you may want to look at the aggravating factor or relieving factor when it comes to pain. If the woman is having a menstrual loss, heavy menstrual loss, also you want to know the duration, how it started, compare it with when the blood flow was normal, like the first years of perimenarche years. You need to know how normal this blood was at that time. Yes, you may want to know the amount, particularly if the woman is having a vaginal discharge, the odor, the color, and if the discharge is blood stained. This is very important because if the vaginal discharge is blood stained, it may be pointing in direction of carcinoma. We want to find out whether the symptoms are abating or getting worse. Then it's also important that you relate these symptoms to the events in the life of the patient. These symptoms, be it a vaginal pain, be it an increasing abdominal size, how does it relate to the menstrual cycle? Or how does it relate to the mood of the patient? How does it interfere with the sexuality? Is there any pain during intercourse with it? Or is there any dysmenorrhea? Does it affect fertility? Is it associated with sleeping disorders, urination or defecation, or starting a new job, or a new relationship, an emotional change in patient's life? For example, if there is what we call excessive menstrual blood loss. Once these basic symptoms are identified, we need to look at the history of the etiology of the symptoms. Because usually the etiology of that symptom, for instance, if a woman comes with the complaint of difficulty in getting pregnant, difficulty in getting pregnant could be as a result of infection from pregnancy, from termination of pregnancy, from sexually transmitted infections. You need to take history of previous infections, history of sexually transmitted infections, history of previous termination of pregnancy, and history of drug use. They are very, very important. Again, apart from the history of etiology, you need to find out the history of complications. History of complication of that symptom. That is, for instance, if a woman is bleeding excessively, after a period of time, the bleeding is excessive, the woman may be getting tired, getting weak, or unable to eat. So all these things, or fainting, evidence of fainting, you may want to find out if the woman has some fainting spares to establish complications of that. But again, if a woman has an abdominal mass that subtly ruptures, there could be some fainting attacks. The history of drug use or previous treatments, you may find out, if this woman has taken some drugs or she has been to a private hospital before coming to you, and what type of treatment she has been given. She has had a radiotherapy, for instance, or a chemotherapy. So it's also important that we know that. The history of previous investigations. What investigations has she done before coming? It's possible she has had an ultrasound done. It's possible she has had an X-ray. Or any of the investigations, you need to have an idea of what she has had. History of blood tests, laparoscopy, or biopsies. And as I'm taking this history, you need to make a high contact with your patient. You're able to know when the woman is deceiving you, or when a woman is trying to hide information about the problem at stake. And as much as possible, you should avoid using technical terminology that may confuse the patient. Then after taking this history of the presenting symptoms. Then you now look at past medical history of this woman. Past medical history. History of previous contraceptive usage is very important. History of medication, as we have said, in the systemic history. And then history of diabetics, history of hypertension, or history of cancers, and probably history of psychiatric illness. All these things may be important in obtaining a very good history. Very good history. History of allergy, history of bleeding, diathesis, they are very important. After the past medical history, we need to go to the family history. The family history is of great value in identifying what the problems are. And this family history should include the state of health of immediate relatives, parents, siblings, grandparents, and offsprings. Because, like history, the diabetes could be passed on to the offsprings. So we need to know if there's a family history of diabetics, a family history of hypertension, family history of sickle cell anemia, or family history of bleeding disorders. These are very important and they should be documented. Again, it's also important to know the family history of breast cancers, ovarian cancers, colonic cancers. Then, time of menopause in the grandmother or in the mother. It's also important. And some people may come with premenopausal features at earlier than that or much earlier than that. An idea of the age of menopause in the mother or grandmother may help you in making a diagnosis. In antenatal clinic, family history of twins or multiple pregnancies, sickle cell disorders, asthma, and CBATs are very, very important to note. And we now go to the social history. The social history, the knowledge of the type of work the patient does is very, very important. And this is one of the things that we use to calculate to know the socio-economic status of women, the work. The educational background is very important, as we said in the earlier segment. Knowledge concerning diet, health screening, pap smear, for instance, recreation, degree of physical exercise. And it's also important to know whether this woman smokes or take alcohol and quantify it as part of the social history. And after taking the social history, we shall go to the systemic review. And this systemic review must take into account all the systems of the body, the central nervous system, the cardiothoracic system, the gastrointestinal system, and then the musculoskeletal system, and again, the reproductive tract. So with the central nervous system, you need to inquire if there's some degree of sleeplessness, restlessness, or irritability, mood changes, headaches, usually headaches that involves the frontal area may affect vision, may affect hearing loss, and all these things need to be noted. It's also important to find out if there is a neck swelling, thyroid swelling, or hoarseness of voice. And in the gastrointestinal system, we want to find out if there is a regular bowel movement, or there is constipation, or there is alteration of diarrhea with constipation. Those ones that's also meaning. Vomiting, nausea, pains at defecation may occur with endometriosis. Difficulty in eating, swallowing is also very important. Many patients with a slight problem, they may not be able to eat. Nutrition, assessing the the renal system is also very important. Look at the frequency of urination. Is there any painful urination that we call dysuria? Is there any incontinence, any spontaneous release of urine, either with cough or with strain? Or is there any blood in the urine that we call hematuria? Or if there is any costovertebral angle like backache pain? All these things are very important to assess the renal status of this patient. Cardiorespiratory system is also important. This assesses the cardiac and respiratory system. Look for evidence of angina, pains, central pain in the chest, difficulty in breathing, breathlessness, bluish tendencies, fainting attacks. All these are referable to the cardiothoracic system. And finally, emotional problems. Emotional problems. This may involve a tactful inquiry about sexual relationship with the husband, which she may not want to disclose. And this may be probably be one of the reasons why she's coming to you that she doesn't want to disclose. Or family problems. Family problems, some form of disagreement in the home, or the children not doing fine, you may want to find out. And this may be part of the things that could add to the problems of your patient. Then, housing and occupational stress, one needs to inquire about this one. And in taking this history, in going through this system, you are more likely to take a very good and informative history that will help your patient. The way I've simplified it out looks so simple, but needs to be thoroughly learned and mastered. A physician must be very quick in getting relevant information from the patient, focusing on the essentials, and yet be more detailed and systematic. A detailed history should contain the essentials described above. But in certain situations, as in examination, a stakeholder must design a way of getting this information within 5 minutes, particularly in objective structured clinical examinations or in oral clinical examination. I thank you for listening to me at these first lectures, and these are my references.